everybody. Welcome to this session focused on anticoagulation and cancer. My name is Teresa López. I work at La Paz Hospital in Madrid, Spain. And my co-chair is Dr. José Luis Merino, an electrophysiologist, also at La Paz Hospital, and the current president of the European Association of Arrhythmia. This session is focused on a really hot topic. And for that purpose, we have three spectacular speakers who are going to review what's new in arrhythmias, how to manage atrial fibrillation in cancer patients, and how to manage cancer-associated thrombosis. So please, you are welcome to participate using the chat. We want to remind you that you need to attend the live session in order to be able to claim the credits. And due to the time restriction we have in all this session, we are directly go to the first presentation. It is my pleasure to introduce you Dr. Michael Fradley. Is the medical director of the Cardio-Oncology Center of Excellence at the University of Pennsylvania. Thank you, Mike.
Thank you, Teresa, for the invitation to speak today, and really congratulations on a spectacular meeting. So I'm going to start talking about what's new in arrhythmia management for cancer patients. It's an area that is still, I think, evolving in the field of cardio-oncology, but more and more data is certainly coming through. I think there's just a little delay. There we go, my disclosures. So objectives for today's talk are really threefold. First, I want to review some of the current state of knowledge that we have of cancer treatments and their associated arrhythmias, and then discuss some of the novel data that exists regarding arrhythmia management in cancer patients, as well as highlight some of the challenges that we have regarding the management of rhythm disorders in patients with active cancer. So I wanted to start off by mentioning a few of the cancer therapies that we know have an arrhythmic risk. And first, we'll do the BTK inhibitors. So you'll hear more about ibrutinib-associated atrial fibrillation in subsequent lectures. However, I think it's clear that ibrutinib is associated with incident atrial fibrillation. So in this systematic review and meta-analysis, the rate of ibrutinib-associated atrial fibrillation is 3.3 per 100 person years, compared to 0.86 per 100 person years for non-ibrutinib regimens, with a relative risk of ibrutinib-associated atrial fibrillation of 3.86. But beyond just atrial arrhythmias, ibrutinib is also associated with ventricular arrhythmias. So when you look at the FAERS data, there were 13 cases of ventricular arrhythmias with 6 episodes of sudden death. And the majority of these patients did not have a history of baseline cardiovascular disease. And then a follow-up study showed that the incidence of ventricular arrhythmias was 596 per 100,000 person years. So while this is a relatively rare phenomenon, it's still quite important because ventricular arrhythmias obviously can lead to very severe bad outcomes. Now, there's actually been some recent data suggesting what the mechanism may be behind ibrutinib-associated arrhythmias. Now, unlike a lot of other cancer agents, ibrutinib does not seem to prolong the QT interval. So QT prolongation is not the cause of these ventricular arrhythmias. And in fact, it appears as though ibrutinib will actually shorten the QT interval. So with this in mind, Zhang and colleagues published a really nice study in Heart Rhythm that demonstrated abnormal calcium handling in atrial myocytes that were exposed to ibrutinib, with the amplitude of calcium release significantly decreased in those myocytes that were exposed to ibrutinib. So this might speak to a mechanism by which ibrutinib generates its arrhythmias. Now, moving into the category of immunotherapy, we know that both bradyarrhythmias and tachyarrhythmias can be the initial manifestation of immune checkpoint inhibitor myocarditis, as was demonstrated in this initial report published in the New England Journal of Medicine. Now, in this study from JACC Cardio-Oncology, you can see that arrhythmias and cardiomyopathy really dominate the list of immune checkpoint inhibitor adverse cardiovascular events. And then when you dig a bit deeper into the data that exists, in this study by Escudier and colleagues shows that atrial fibrillation followed by ventricular arrhythmias and conduction abnormalities are really the most common rhythm disturbances that you're going to see in patients treated with checkpoint inhibitors, on the range of around 20 to 30%. Now, an interesting question is whether there is a long-term risk of arrhythmias after ICI myocarditis resolves. Now, this question hasn't been specifically addressed. However, there is data to suggest a higher incidence of ventricular tachycardia, overall mortality, as well as ICD implantation, even many years after recovery from other types of acute myocarditis. And I think that this is going to become an increasingly important question as our treatments become more sophisticated and patient survival increases. We're going to need to think about whether or not these patients that have recovered from their myocarditis may be at long-term risk for arrhythmias. We do know a lot about chemotherapy-induced cardiomyopathy, although the burden of arrhythmias is something that has only recently been quantitated. There's been 2 studies that have looked at arrhythmias in patients with this specific type of cardiomyopathy. And in both studies, the authors demonstrated that there was really no significant difference in arrhythmia burden amongst patients with a chemotherapy-induced cardiomyopathy and other forms of non-ischemic cardiomyopathy. There may be a slightly increased risk of ventricular arrhythmias in patients with ischemic cardiomyopathies, however. Moreover, the group from Mayo, led by Dr. Herman, also showed that patients with an anthracycline-mediated cardiomyopathy had no significant difference in overall mortality when compared to these other cardiomyopathy etiologies. Now, as far as management of atrial fibrillation, I'm not going to go into anticoagulation because you're going to hear about that in subsequent talks. But at least as it relates to rhythm control, I think you'll see that we have a lot left to learn with regards to managing AFib in cancer patients. For DC cardioversion, it's been generally thought that this modality is less effective in cancer patients. That being said, it hasn't been specifically evaluated in any population outside of the amyloidosis group. So this was a study of 58 patients, half of whom had AL amyloid, and they compared it to 114 matched controls. The amyloid patients had a significantly higher cardioversion cancellation rate, which was primarily due to the presence of left atrial appendage thrombus. However, success rate of cardioversion, at least in the acute setting, and the likelihood of arrhythmia recurrence was not significantly different between the amyloid patients and the non-amyloid patients. And procedural complications tended to be more common amongst amyloid patients, primarily the development of conduction block leading to pacemaker placement or ventricular arrhythmias. But I think that this is an area that needs to be investigated in other cancer populations, both those that have a history of, but also those that might be receiving active therapy. And what about catheter ablation for AFib in cancer patients? Well, there's only been one study that has looked at the safety of catheter ablation in cancer patients. And in this study, they showed that cancer patients had a pre-procedural risk of clinically relevant bleeding more frequently than in patients without cancer, particularly when propensity score matching was performed. They did not comment on procedural efficacy, and there's actually been no study to specifically look at whether or not catheter ablation is as effective in cancer patients as non-cancer patients. Moreover, I think we're going to need to really look at specific populations. Those patients that are receiving therapies, do we think that this is a therapy-induced atrial fibrillation event versus simply cancer-related atrial fibrillation related to, say, the inflammatory state that exists in a cancer population? Moving into device management of arrhythmias in cancer patients, we actually have some data about implantable cardiodefibrillators. This comes out of Denmark, looking at around 5,600 patients who had an ICD implanted. 5.1% of these had cancer. And interestingly, of that group, half of those patients had been hospitalized in the preceding 3 months for some cancer-related issue, indicating that their disease was still active. So this was not just simply people with distant cancers. The most commonly represented cancer was male GU cancer, so prostate cancer, not surprisingly. And then, of course, those cancers that have very poor prognoses, like pancreatic cancer, are not very well represented. Now, when you look at overall mortality, there was no significant difference in patients who received a primary prevention ICD, both at 1 year or over all time, if they had cancer or if they did not have cancer. However, if you look at the patients that received a secondary prevention ICD, there was increased mortality amongst those patients with cancer, both at 1 year and all time. So this may suggest to some people that we need to be more strict in the patient population we would consider putting an ICD in. However, if you start to look through the data a little bit more deeply, 2/3 of the patients who received a secondary prevention ICD were still alive at 3 years. And half of those patients who received a secondary prevention ICD had an appropriate ICD therapy, thus saving their lives. So actually, I think we need to be very thoughtful about considering ICD therapy in the right cancer patient population. And then if you look at these bar graphs, you can see that there's really no significant difference in the cause of mortality, whether it is cancer-specific mortality or cardiovascular mortality amongst those patients that were receiving ICDs, with the exception of patients who had a primary prevention ICD, in which all-time mortality was higher in those patients from a cardiovascular cause, not from a cancer cause. We also now have some data showing that cardiac resynchronization therapy is quite effective in patients with chemotherapy-induced cardiomyopathy, similarly efficacious as it is in other cardiomyopathy etiologies, and that was from the published Made It Chick trial. In this study, 30 patients were enrolled. The mean age was 64, 73% had a history of breast cancer, and the median QRS duration was 152 milliseconds. And over the 6 months of the study, you can see that the baseline ejection fraction improved to 39%, that the left ventricular end systolic volume declined to 89 milliliters, and the left ventricular end diastolic volume declined to 143.2 milliliters, all of which were statistically significant. As well, the New York Heart Association class improved in 49% of the individuals in this study, and this held true when looked at different subgroups. And lastly, I just want to touch on a new frontier in cardio-oncology. You know, we talk a lot about how cancer treatments lead to adverse cardiovascular effects. But is there the possibility of leveraging cancer treatments to potentially fix arrhythmias? And that is really the case that was shown with the non-invasive ablation of ventricular tachycardia using stereotactic body radiation therapy, or SBRT. And this is the traditional technique for delivering radiation therapy. So in this study, the ventricular scar is mapped using MRI or CT, and then the ventricular tachycardia is actually mapped using non-invasive techniques from a patient's implantable defibrillator. Then, in conjunction with radiation oncologists using standard SBRT simulation and planning techniques, a single dose of 25 grays of radiation is delivered to the ventricular scar while the patient is awake. And in this study, albeit only 5 patients, but nonetheless over 46 patient months of follow-up, there was a 99% reduction in ventricular tachycardia episodes from baseline. So I think this is going to be a very interesting area in the overlap in oncology, cardio-oncology, and electrophysiology. So in summary, arrhythmias are a common occurrence with various cancer therapies, including BTK inhibitors and immunotherapy. Cancer patients seem to derive at least similar benefits from rhythm control as non-cancer patients, though we really do need to investigate this further. ICD and CRT therapy benefits cancer patients and survivors with cardiomyopathy. And then for some future directions, I think we need research utilizing novel technology for rhythm evaluation and management in cancer patients, particularly leveraging some of our wearable technologies. We need a better mechanistic understanding of cancer treatment-associated arrhythmogenesis. And finally, leveraging cancer therapies, particularly radiotherapy, may be an interesting way for us to approach the management of arrhythmias in the general population as well. I want to thank you all for your attention.
Thank you, Mike, for this a standing presentation, very interesting. I am looking forward for the time for discussion to ask you several questions. But now we need to move forward, and the next speaker, I think that he doesn't need any presentation, is José Luis Zamorano from Hospital Ramón y Cajal in Madrid. He is a well-known cardiologist in Europe, heavily involved in the European Society of Cardiology, and he has many other merits that I don't need to tell you. Pepe, please.
Thank you, José Luis, for these extremely kind words. Dear Teresa, dear colleagues. Well, I think that after the brilliant presentation from Mike, there is no doubt that there is a clear relation between cancer and atrial fib. In fact, the question of cancer and atrial fib, the first question is how often is it? And we can see here in this nice and elegant paper that patients with cancer had a 20% higher adjusted risk for atrial fib. So in fact, atrial fibrillation begets cancer. But also, we should think that there are some specific type of cancers. As you can see here, the incidence of cancer in women with new onset of atrial fib, you can see that atrial fibrillation was a significant risk factor from the incident cancer in age-adjusted models and in the multivariate analysis. So in fact, is the relation between atrial fib and cancer, but also cancer and atrial fib. And there are different possible explanations for that relation, but no doubt that there are common paths, common etiologies between cancer and atrial fibrillation. So we should never forget the inflammatory response in the neoplastic processes, the hyperadrenergic status in these patients, the electrolyte disarrangement, metastatic involvement, or paraneoplastic syndromes that can also be related to the presence of atrial fibrillation. But also the treatment is quite relevant because there are clear relations, as you have seen, between the therapy and atrial fibrillation. And in fact, there is a relation for the drug-induced presence of atrial fibrillation from the different agents that we can use in different cancers. And it has been said that up to 10% of the atrial fibrillation present in cancer patients can be related to the therapy that we are giving to our patients. So in fact, there are common mechanisms between atrial fibrillation and cancer, and there are the arrhythmias that are related to malignancy itself. There are arrhythmias that are related to the therapy itself, and also it could be atrial fibrillation that is unrelated to malignancy. But again, the complication is not only the prevalence, the high prevalence of atrial fib in cancer patients, it's also that the complications implies worse outcome for our patients with cancer. In fact, we have an increased cardiovascular mortality, we have a higher rate of stroke and systemic embolism, heart failure, or bleeding are the most common complications. So how to manage that? We have an increased bleeding risk, and we can evaluate that with the Hasbled, but also we have an increase of stroke, and we can evaluate the risk with CHA2DS2. But we should never forget that CHA2DS2 has not been validated specifically for cancer patients. And maybe we should think in a new score, including cancer and the type of cancer, to evaluate the risk of stroke in these patients. Well, things to consider. There are some things, in the same way as with the CHA2DS2, there are some risk factors that implies a higher rate of thromboembolic risk, like the type of cancer, the cancer stage, the therapy that we use. And also, we have some particular fields that are related to bleeding risk. And again, we can overlap some risk factors that implies higher risk for both, for thromboembolic or bleeding risk. Well, how to treat, how to prevent? What do we know about anticoagulation in cancer patients? Well, I think that no doubt that vitamin K antagonists, we have a lot of potential drug interactions, and it may lead to a really unpredictable anticoagulant effect. Well, there's no question about that low molecular weight heparin is clearly preferred over warfarin. It could have potential anti-angiogenic effect. Aspirin as in the guideline is already stated, no use for stroke prevention, and weak evidence, but we have some related to the DOACs. Well, we have published a couple of things, a couple of papers even in our journal in Revista Española de Cardiología, that clear patients with the breast cancer, we have a worse outcome and worse prognosis, I will say, by using the anticoagulants. Also, we know that we have a higher incidence of these patients with stroke in patients with breast cancer, with a similar bleeding rate in our series. And there is no doubt that I am absolutely sure that in the near future we will have new evidence how to do or how to treat these patients related with the anticoagulants. Do we have some data related to DOACs? In fact, we can extrapolate some data from the pivotal trials of the DOACs, although we should realize that there is not a specific trial that is really dedicated or focusing in cancer patients. But from Aristotle, with apixaban, we can be sure that the effect of apixaban for prevention of a stroke or systemic embolism was consistent among patients with or without cancer. And in the ENGAGE trial, if we see what happens with patients that develop cancer throughout the duration of the study, we can see in this graph that in dark green, we can see patients with malignancy. In light green, we can see no malignancy, and there was a higher incidence of bleeding, major bleeding in patients with malignancy. So in fact, dear colleagues, Teresa, José Luis, I think that I think that we can conclude that there is no doubt that there is a high prevalence of atrial fib in patients with cancer. So we need to focus on this problem. There is a multiple reasons why the common path of the etiology of cancer and atrial fib are really joining together. So this implies that higher increase of atrial fib and higher increase of cancer prevalence in atrial fib patients. So both directions. We know that atrial fib itself provides a worse outcome in cancer patients. I think that they already have an increased thromboembolic and bleeding risk. And I think that DOACs may be an alternative for a long-term treatment in these patients, although we should admit that there is no specific long-term trial of cancer patients on how to anticoagulate in the long term. Thank you for your attention.
Thank you, Pepe, for your outstanding presentation. I'm sure that we are going to still receive a lot of questions on our chat. And it's time to move to the last presentation of our session. It is my pleasure to introduce you Dr. Sebastian Szmit. Dr. Sebastian Szmit is the director of the Cardio-Oncology program in Poland and also the president of the International Cardio-Oncology Society Poland chapter. And please, Sebastian, you want?
Thank you, Teresa. I hope you can hear me.
Perfectly.
Great. Thank you. Great pleasure to be with you during this session, during this event. Congratulations for organizer, and thank you for including me. I have the great honor to work with amazing oncologists and hematologists in Poland. I have the cardio-oncology at my home because my wife is oncologist. She is my teacher. And this is my statement of conflict of interest. And I would like to remind you that a few years ago, we knew the guidelines published by European Society of Cardiology and American Society of Clinical Oncology, and we could consider to use low molecular weight heparin for patients with cancer disease and pulmonary embolism or cancer-associated thrombosis for at least 3 to 6 months. ASCO guidelines prefer to use anticoagulation during 6 months of therapy, and we could not use the oral anticoagulation. direct new oral anticoagulants because we didn't have enough data about efficacy and safety of this group of drugs. And last year, European Society of Cardiology published the new guidelines with new recommendation to understand edoxaban or rivaroxaban as alternative to low molecular weight heparin, but we shouldn't use this drug in patients with gastrointestinal cancers. If we would like to evaluate, to discuss these guidelines in details, we should remember that weight-adjusted subcutaneous low molecular weight heparin stayed as the best option for treatment for cancer patients for the first 6 months of therapy of anticoagulation, and we can use edoxaban and rivaroxaban, but we have the significant difference in the level of evidence, B for edoxaban and C for rivaroxaban. This is the results of the data published by the expert from the clinical trials from Hokusai and SELECT trials. As you can see, the trial with edoxaban was significantly larger, with more than 1,000 of patients from more than 100 centers in 13 countries. But the SELECT trial with rivaroxaban was significantly smaller, conducted in the United Kingdom, and only 400 of patients were included in this trial. And now we know that the efficacy of edoxaban is not inferior in comparison to dalteparin, but we can expect of the rate of bleeding because patients treated with edoxaban could experience more frequently major bleeding in comparison to arm with dalteparin. The SELECT study was very interesting because we can be aware that rivaroxaban may be more effective in comparison to dalteparin, but you should remember this study was very small, and rivaroxaban is a good drug, but we can't afraid of the risk of bleeding once again because the patients with gastrointestinal cancers could experience bleeding more frequently. And of course, European guidelines didn't say anything about apixaban because the good data about this drug came this year. The Caravaggio study was published in March, and now we know that we have the first drug with the optimistic efficacy and safety in comparison with dalteparin. Apixaban may have the same safety and the same efficacy in comparison to dalteparin. If you would like to evaluate all drugs from the available data from the clinical trials, 4 clinical trials, we can conclude that the risk of recurrent thromboembolic disease may be reduced about 40% when we use new oral anticoagulants in comparison to dalteparin. That's very optimistic for our daily practice. The problem is with the bleeding. The risk of major bleeding may be very similar when we compare new oral anticoagulants with dalteparin, but the risk of clinical relevant non-major bleeding may be observed more frequently in patients treated with new oral anticoagulants in comparison to low molecular weight heparin like dalteparin. And we know that the highest risk of bleeding may be observed in patients, cancer patients with upper GI cancers, and the risk of bleeding may have the borderline significance for the patients, cancer patients with lower GI cancer diseases. And now I would like to focus your attention on two another difficult situations, clinical situations. First of all, I would like to remind you about the possibility of extended anticoagulation beyond the first 6 months of treatment, dedicated for cancer patients with active disease, for patients with disease needed to continue anti-cancer treatment. And the second situation, very important, includes the patients with incidental pulmonary embolism who need to be treated in the same way as the patients with full symptomatic pulmonary embolism. And we have enough data now that we can use new oral anticoagulants because, in my opinion, when we use these new drugs, we can expect the significantly lower risk of recurrent thromboembolic disease. And of course, we can be sure that the cancer patients who need long-term anticoagulation beyond 6 months of therapy would prefer to receive oral direct anticoagulants rather than low molecular weight heparin, which is administered by subcutaneous way. So that is fine that we can read the ASCO guidelines. ASCO guidelines allows us to use oral anticoagulants, new direct oral anticoagulants, as well as vitamin K antagonists in the special situations like the patients with severe renal dysfunction. In my opinion, this is very important. And the last problem in the clinical oncology. Thank you. We can offer the primary prophylaxis with apixaban, rivaroxaban, or low molecular weight heparin for cancer patients during active anti-cancer chemotherapy. The definition of high risk of thrombosis in such situation was adopted from Corona score with 2 or higher points. And we know the data from Cassini and other trials which confirmed the high efficacy of rivaroxaban and apixaban for patients in primary thromboprophylaxis. But the next problem, once again, is the risk of bleeding. We can expect the significantly higher risk of bleeding. And as you can see, the risk is significantly higher for apixaban, but in defense of this trial, I can add that other trial could include the patients with concomitant antiplatelet therapy. In my conclusion, who is the best candidate for new direct oral anticoagulants? We should avoid this group of drugs in cancer patients with high risk of thrombocytopenia, with high risk of drug-drug unbeneficial interaction between oral anticoagulant and anti-cancer therapy. And we should avoid new oral anticoagulants in patients with high risk of bleeding, especially in patients with gastrointestinal cancer. However, we should remember the data from Caravaggio study, and we can consider to use apixaban. And thank you for your attention, and thank you for my best friend from my clinic who every day helped me to develop cardio-oncology in my hospital. Thank you.
Very much, Sebastian, for your fantastic talk. And now we have some time for discussion and for questions. So I remember the audience that they have the possibility to ask their questions through the chat of this session. And in the meantime, we have several questions to the speaker. I will start with Mike, and we have received one question from Alex Leon, and he has a spirit of engineer, saying that in the spirit of reverse cardio-oncology, there is a interest, or could be the interest. For example, we know that BTK inhibitors induce AFib, so this may be the rationale to develop new drugs like BTK agonists in order to treat AFib patients. What do you think, Mike?
Yeah, I mean, I think that that's a very interesting question, and I think that it speaks to the kind of the exciting part of cardio-oncology is, you know, not simply thinking about this as just toxicities of cancer therapies, but are there ways in which we can think mechanistically outside of the box and leverage cancer therapies and what we're learning from them to actually better manage cancer or better manage cardiovascular disease, whether it's arrhythmias or something else. So I think it's a really cool question and something that probably should be looked into.
Okay.
We have another interesting question, this time for Dr. Zamorano. Pepe, the audience wants to know two important questions. First, when to consider screening for atrial fibrillation in cancer patients. And the second one is how the age may modify the risk of embolic event in patients with theoretically low risk of embolic event and atrial fibrillation.
Yeah, well, I think that both are extremely interesting. I think that starting with the age, well, we don't have a chat mask specific for cancer patients. I think we need to do that. But I think that age obviously increase the risk of embolic events in patients with atrial fib, and also age increase the risk for atrial fib in cancer patients. So I think that age plays a major role in that, for risk for developing the disease itself, the atrial fib, and the complications. And secondly, when to do or when to check that. I think that now the paradigm has really changed with the new atrial fib guidelines. I mean, we should consider that only 30 seconds of a rhythm, just one lead, ECG one lead, or a device, a portable device, whatever you can use, this implies that you can diagnose atrial fib. So when to do that, I think that we should have a baseline ECG in every single patient that enters in the cardio-oncology clinic, because we should monitor drugs, also rhythm or whatever. And then we should also test an ECG Holter monitoring or portable devices when the patient develops symptoms. So palpitation, something like that, we should check.
Okay.
Thank you.
We have here one question for you, Sebastian, that is about the barriers of DOAC treatment. And you know that these drugs have this somewhat restricted due to economical reasons. So we would like to know what is your opinion on this? Do you think on your local opinion, what is the situation in Poland, in the rest of Europe, and also in the States about the use of DOACs? And if these drugs may also have limitation to be prescribed in cancer patients, because they, as you said, it's not a standard indication.
Thank you for this important question. I can confirm that new oral anticoagulants are very expensive in Poland too. So we can discuss about personalized choices in cancer patients. I prefer new anticoagulants in patients with young patients, especially with incidental pulmonary embolism or thrombosis, with expected good prognosis, good outcome. And I, of course, should hear about preferences of patients. So the price is very important for many patients. But if there are no additional risk for bleeding and drug-drug interaction, I try to prefer new oral anticoagulants. And of course, I observe the additional risk factors like atrial fibrillation, of course, and coronary artery disease. And in such situation, I prefer new oral anticoagulants based on the data, optimistic data from the general population that the efficacy of these drugs should be optimistic in cancer patients too. So when we use new oral drugs, we should remember about personalized choices in cancer patients. That's my opinion.
Thank you for your clear answer. In order to start thinking in other aspects, for example, one of my doubts when I treat this kind of patient is whether atrial fibrillation is a primary disease or a transient disease. For example, you know that in order to treat with anticoagulation our patients, we require that atrial fibrillation is let's say, is not a transient thing. So imagine a patient that you have a patient with cancer that is treated with these drugs that immunocompromise the patient, and the patient develops pneumonia. Under pneumonia, the patient develops atrial fibrillation. After a while, the patient is cured, cancer is reversed, and then the doubt is if there are residual risk factors. Should you treat this patient chronically with anticoagulants, or would you stop and consider that atrial fibrillation was a transient event?
Mike?
Yeah, I think that is, I mean, I think you're really kind of getting to the core of the questions that we have in the realm of arrhythmia management in cancer patients, is really whether or not, especially if this is arrhythmia that develops in the setting of active cancer therapy, whether or not this will develop into a long-term problem. And I don't think we know the answer to that. Or I know we don't know the answer to that. If you extrapolate, say, from patients who develop postoperative atrial fibrillation, we've come to recognize that in that population, you know, what was once thought to be this benign condition probably is not, and that these patients have recurrent episodes down the road because they have, you know, atrial myopathies and such. So, you know, my gut feeling is that at least for some of these therapeutics, there probably is something that's going on mechanistically and pathologically that makes them more likely to develop atrial fibrillation in the future. But I think that this is where we really need to do some research and do some actual long-term arrhythmia monitoring in these patients to determine whether or not a risk persists after the inciting therapy is stopped.
Perfect. Thank you.
Focus on this topic, but one step more. Is there, we have here a question from the audience, is there any biomarker or cardiac imaging technique that could help us in predict which patients are going to have recurrent atrial fibrillation after a first event, probably Pepe?
Yeah, well, I think this is, I think the atrial fibrillation term is too wide. I think that the arrhythmologists need to go deeper in the classification. And here, for me, the main issue is, do we have atrial involvement or atrial disease, atrial fibrosis, yes or no? And is it transient or no? I think that MR may be useful to detect the patients that have intrinsic atrial disease, and this may lead to the differentiation who to treat and for how long.
Yes, a good opinion, but I think that the points raised by Mike were very well taken, because in the past we considered some diseases, for example, AV block developed during antiarrhythmic drug therapy. We thought that this was a transient thing that was due to the antiarrhythmic drug therapy. However, nowadays we have learned that in most of these patients, there is a substrate of arrhythmia that is unmasked by these drugs or by a particular disease. So I think that the point raised by Mike was well taken, and probably most of the patients developing atrial fibrillation during cancer have already a substrate underlying, and probably they merit to be treated. Okay, more questions from the floor. Sebastian, in what kind of patient you still will consider the use of alternatives to DOACs when you treat patients with warfarin and when you treat patients with heparin or other drugs? Do you see still a great space for them?
A very practical question, thank you. We should remember, first of all, that low molecular weight heparin are still the first choice of treatment in cardio-oncology and cancer patients with thrombosis. Especially, we should use low molecular weight heparin in patients with higher risk of bleeding. The good example is the patients with gastrointestinal cancers, especially upper GI cancers. This is the first group, and we should remember about urological cancer and sometimes patients with lung cancer with high risk of bleeding, and of course the population of hematological cancers. In my daily practice, I use warfarin and other vitamin K antagonists in patients with severe renal dysfunction during long-term therapy. The indication is well defined in general population, and we should adopt these guidelines to cardio-oncology. And of course, sometimes I have to use unfractionated heparin for patients with severe pulmonary embolism with high risk of shock, hemodynamic shock. In my opinion, this is the best way, because low molecular weight heparin may be not efficient like the infusion of unfractionated heparin. So we prefer in such severe patients unfractionated heparin. I hope that my answer is sufficient.
Yeah, thank you, Sebastian. Teresa, I don't know if we still have...
I think that we need to close the session in order to be on time. So if you want to close, José Luis.
Yes, thank you, Teresa. I thank the organizers, the International Oncology Society and Spanish Cardio-Oncology for this superb session, the speakers and the audience for being today with us. And we expect that you still get connected to the rest of the Congress. So thank you to all.
Thank you.